Okay, Bismillah ar-Rahman ar-Rahim. Welcome back from the vacation and welcome in this new year, fourth year. Today we will cover the topic of the oral lesion, the pathological aspects of the oral lesion. We can divide these oral lesions into two broad categories. The number one is non-neoplastic and the other one is the neoplastic. What is neoplasia? Cancer. So means non-cancerous and cancerous. Okay. So non-cancerous is a broad category, very broad category, and this will be the main focus of our today's lecture. We will not cover in detail the neoplastic lesions. They will be covered elsewhere in your modules. Okay. Today we will cover this mainly non-neoplastic lesions. Okay. Now you can see that it is further categorized into two main categories, stomatitis and white plaque. And this stomatitis is further divided into ulcerative stomatitis, and depending on the cause or the morphology, we further divide into subtypes. And the white plaque is divided into three categories. So it will be not very cumbersome or very difficult, inshallah, if you will just focus on the main points. Okay, number one, we are starting with non-neoplastic, non-cancerous lesions. As I have told, we will not focus cancerous, we will focus on the non-cancerous. So we are here, ulcerative, we are here. First of all, this herpetic stomatitis, okay? Okay. So herpetic, can you judge what will be there? Herpes. So very simple. So depending on the cause, the causing agent, they named it herpetic stomatitis. Okay. Word itis, something telling you? Very good. So inflammation. So by looking at the name, you can judge what is there. This is inflammation of the oral cavity due to herpes simplex virus. Okay. So herpetic stomatitis is a viral infection, herpes simplex 1 or 2 of the mouth that causes ulcer and inflammation. So very simple. Definition is very simple. Now the pathology, these are the picture of the lesion. So very small vesicles which are filled with fluid. Okay, the fluid inside the vesicles. So appear vesicles, small means they are small lesions on the mucocutaneous junction of the lips and buccal mucosa. So they are at the mucocutaneous junction, usually at the lips. So the junction between lips and the skin. And clear serous fluid is there. The serous fluid, just like a water, is there, and the few leukocytes are there. And when they rupture, they leave a shallow, painful red ulcers. So in short, this is an ulcer. So as you know, ulcer, what is ulcer first of all? Any idea? So it is the damage of the superficial layers, okay? Damage of the superficial layers of any surface. So just like a wound, so you should know the ulcer. So we are talking about the ulcer in the mouth oral cavity. So this ulcer is caused by herpes, the inflammation, and main point is that it is filled with serous fluids, small ulcers or vesicles filled with serous fluids, and it can spread to eyes. So this is one of the complications, and it can be very painful, which can lead to difficulty in taking food, and ultimately the complications of less food intake or water intake can develop. But the main point which I will suggest you to focus is the cause, the causing agent, and these important points, the vesicle and serous fluids, and there are few complications. Okay, the next second one, aphthous stomatitis, also called as canker sores. These are very common in population, very common. Usually what the people come across, their ulcers in the mouth, these are usually the aphthous stomatitis, usually. So very common. The most common oral lesion, mucosal lesion of unknown etiology. So we don't know. All of a sudden, once we get up in the morning, we feel there's some ulcer in the mouth. So we don't know the cause. What is the cause? But maybe stress, maybe some other genetic factors are there. We don't know exactly. Okay. So what are these ulcers in the mouth? They appear single or multiple shallow hyperemic ulcers. So it can be one, single, it can be multiple, but usually they are shallow, they're not very deep. And the hyperemic means a lot of blood, or usually if you see there's red around the ulcer. Ulcer is white, but there's reddish area around the ulcer. So these ulcers are covered by thin exudate and rimmed by narrow zone of erythema. The same thing, they're surrounded by erythema, means blood vessels are there, so a lot of blood there. Again, the itis means inflammation, so inflammatory infiltrate of large mononuclear cells, but secondary bacterial infection can be there. So obviously if there are ulcers, the bacteria can invade it and make it more complicated. And they usually resolve in 7 to 10 days. So this is one of the most common ulcers. So first of all, we discuss herpes, and the second one, the most common in the population, is called aphthous stomatitis. Aphthous stomatitis. Cause we don't know. Only thing is that there's a lot of erythema, shallow ulcer. Okay, so inflammation will be there. Don't be too much curious about these details. It's very simple detail. Inflammation will be there, and all the cells of inflammation will be there. The third one, syphilis. Okay, we will not describe and cover all the syphilis. We will only focus on this aspect, the oral lesions of the syphilis. So as you know, I think you know that this is caused by spirochetes. This syphilis is called by spirochetes and usually transmitted by kissing. So primary stage of syphilis is usually marked by the appearance of a sore called canker, which develops on either lips, commonly the upper lip. So there are different stages of this disease, syphilis. In the primary stage, usually these ulcers arise around the oral cavity. Okay? The specific shape of these ulcers. So usually they are firm. The previous one were soft. They are firm, round, small and painless. And it appears at a spot where syphilis entered the body. Okay? And the ulcerative lesion with a fibrin covered base and a dense lymphoplasmacytic infiltration throughout the dermis. So this is a microscopic picture that there is ulcer, this fibrin over there. That's why it is thick. Okay, it is firm because of the fibrin over it. And under the fibrin, there are lymphoplasmacytic. So lymphocytes and plasma cells are there. So the important points in this kind of oral lesion, first of all, it is in the disease syphilis. And the syphilis is called by spirochetes. And what is unique, that it is firm, round, painless, and if you see under the microscope, there is fibrin layer, underneath is lymphocytes, the cells of inflammation. Okay? The next one, the fourth one. So these are all non-neoplastic. They're not cancerous. Now look at the word acute necrotizing ulcerative gingivitis. Okay? So if you focus, you can judge what is it. Acute, short duration, necrotizing. Necrosis will be there. Good. Ulcerative. So ulcers will be there. And gingivitis, Gingiva is involved and the inflammation is there, itis. So cause is Treponema vincenti and Bacillus fusiformis. And these are seen in the patient of low resistance. What is low resistance? Anybody? Good. Anything else? Very good. Diabetes. Anything else? Neonates? Good. So these are main causes, low resistance. Okay? So usually seen in the low resistance patients. And if you look at the clinical picture, the progressive painful infection with ulceration and swelling. So look at this. They're very painful, swelling and ulcers are there. This is very important. Sloughing off of dead tissue. So necrotizing. Okay? So if you just mash these things, you will easily remember what the key points. There is sloughing off of dead tissue. The tissue is sloughing. That's why we call it necrotizing. Then necrosis is going on. And necrotizing inflammation is there. And if you see under the microscope, the separation of necrotic mucosa, superficial or deep ulcer infiltrated with neutrophils. So sloughing off is going on. This is the most important point of this oral lesion. And it is very apparent from the name, acute, necrotizing, ulcerative gingivitis. So from here you can remember the place, base it deep into the mouth. And from necrotizing you can remember this point that this sloughing off is going on. Okay? The superficial layer is sloughed off. Necrosis is there. So just match the key points. The fifth one is pyogenic granuloma. So now, word pyogenic, what does it mean? Very good. Pus is there. And pus is usually due to very good bacterial infections. Okay? So bacterial infection usually leads to pus. Okay. So this common in gingivae, clinical presentation, they are solitary, soft, red and friable nodules that bleed readily. They frequently ulcerate. So now they are usually one lesion, and in comparison to the other ulcer, their swelling is there. In other ulcer usually there is ulcer but no swelling. But here this swelling is there and it is very soft. Now if soft and red, so what will be inside it? Very good, blood is there. Okay? So due to blood it looks red, and that due to that it is soft because vessels are there inside. So that's why it bleeds very frequently, easily. So if there is something which can damage it, the bleeding can start because vessels are inside. So for this pyogenic, you can remember that granuloma, when the word granuloma is there, you can easily think of some swelling. Okay, something is protruding out. So from that you can remember that in granuloma, pyogenic granuloma, there is swelling, very soft, red, and you can memorize that there are blood vessels inside and it can bleed. So in the microscopic picture, what you will see? So numerous large, thin-walled, anastomosing blood vessels. So blood vessels are there, simple. So if you remember in the sequence, there is some swelling, granuloma is there, word in the name of the disease or the ulcer. So granuloma, swelling, what is in the swelling? Blood vessels. So if under the microscope, you will see the blood vessels. Okay? And anastomosing means combining. Okay? Many blood vessels are combining to each other. In a loose, edematous and moderately cellular stroma. So it is soft. So that's why it's loose. Something is soft, so connective tissue is very loose. It's not dense. And the older lesions can show fibrosis. So as the lesion goes older, it can show fibrosis, it can become firm. So because there are a lot of vessels, so inflammatory cells are minimal. Vessels are more, cells are minimal. Okay. The next one, now the white plaque. So if we go to the first slide, this one. So we covered these one. We started from there, non-neoplastic and neoplastic. In the non-neoplastic, we covered these. Very easy. Herpetic stomatitis, herpes is the cause. Okay. Aphthous, most common ulcer. Primary syphilis due to syphilis. Okay. And there's a firm lesion. Acute necrotizing, necrosis is going on. Okay, in the gingiva, deep into the mouth. And pyogenic granuloma, some swelling is there, very soft swelling filled with blood. So this we have covered. Okay. Now we are moving to white plaque. Now as the name suggests, there's something white. Okay, so there's something white. Plaque is covering the oral cavity. Something white covering is there. So we will discuss now this. So first of all, monoliasis or thrush. Okay. So the cause is Candida albicans in patients who follow antibiotic or HIV. So again, which are low in immunity. Usually in those patients, this white covering occurs. Cause is mainly Candida albicans. And oral thrush, candidiasis in the mouth of babies, and oral monoliasis in the mouth, throat of adults. So if these are babies, the patient is baby, so we usually call it oral thrush. And if that is the adult person, we call it oral monoliasis. Okay. And it can spread from the oral cavity into the esophagus, deep into the esophagus. Obviously there is no immunity, so it can spread easily. And then it can cause esophageal candidiasis. Anyway, what will you see in the microscope? Simple. Inflammatory cells, neutrophils, and their Candida hyphae. So obviously when there is fungus, the hyphae will be there. So hyphae will be there. So under the microscope you will see those. So neutrophils, the cells of inflammation, and the hyphae. Okay, Candida hyphae. Pseudomembranous candidiasis consists of a mixture of necrotic squamous cells, inflammatory cells, and Candida hyphae. What is pseudomembrane? Huh? Okay. Yes, pseudo means fake, false, not true, and membrane means membrane, something covering. So look at this. It seems something has covered the tongue. So it is not something, it is this Candida hyphae actually are covering this layer. So it looks like membrane. So there is pseudomembranous candidiasis. Okay. So hopefully it's not very difficult. The thrush is mostly seen in those patients who are low in immunity. There are two names you should remember: oral thrush and monoliasis. Difference is of age. Baby is thrush, and old age we call it monoliasis. And it can spread easily, and under the microscope you will see the Candida hyphae, the fungus hyphae. Okay. Next one, smoker's keratosis. So as the name suggests, it is frequent in smokers, and the affected mucosa may show diffuse whitening or mole focal lesion and occasionally pigmented and have a slate blue color. So white to little bluish color is there over in the oral cavity, over the tongue. So usually seen in the smokers. So microscopically, what will you see if you take a section of that? So epithelium can be hyperplastic or atrophic. So it can be hyperplasia or atrophy. Both can be possible, but it's not dysplastic. This is important. What is dysplasia? Sorry? Very good. It's precursors of cancer, but what is it actually?
Disorientation.
Good. So you are using different words to explain it. Actually, plasia is the cell formation. This means abnormal. So cells are formed This means abnormal. Plasia means cell formation. So dysplasia means abnormal cells are formed. Okay? So cells are made more, or there are no cells, atrophy is there. But the important point, there is no dysplasia is seen in these cases. Means cells which are formed are normal cells. Why is it important? Because of this factor. If there is dysplasia, there are more chances of cancer. Okay? It leads to cancer. So if there is no dysplasia, it means it's not cancerous. So and as we have discussed that we are talking only the non-cancerous lesion in this lecture. And there is very variable parakeratosis. So the keratin layer, which is usually over the skin, so it can be increased. The layer of keratin can be increased in these cases. And inflammation will be there. So in the white, plaque or those non-neoplastic lesions, their white covering is there. So we are discussing the smokers keratosis, common in smokers, diffuse white covering, which can be white to light blue color, and under the microscope it can be, cells can be more or less, but they are not dysplastic usually. I am just repeating the key features. Okay. The third one and the last one of this list is the leukoplakia of the tongue. Okay. Now look at the little difference between the first one and this one. It is a white patch of plaque that cannot be rubbed off, resulted from chronic irritation. The first one was due to what? That one I'm talking about, this monoliasis or thrush. It was due to candida. Okay. Now we are talking about this one, leukoplakia of the tongue. Now chronic irritation is the cause. Something chronic, long time, for long duration, something irritative to the tongue, it can lead to this case. And again, it is more common in HIV patient. So what is there? The white patch or plaque, and it cannot be removed from there. So gross picture, what? White thick patches with sharp outline. So this usually circular, or you can identify the margins of the lesion. Okay. And under the microscope, what will you see? The stratified squamous epithelium shows acanthosis. What is that? Hyperplasia of prickle cell layer. Or hyperkeratosis, increased thickness of keratin layer. Okay? And submucosa shows inflammation. So here inflammation, here the layer is very thick. So this thick layer is appearing like this white rounded lesion. Okay? Actually this keratin is more, and the hyperplasia of the superficial layer. Underneath is inflammation. Okay, this one, if it is idiopathic, it is pre-malignant. So this is one of the important points, that it can lead to the cancer. Usually if it is there for unknown cause and circular lesion is there, which looks like this under the microscope with a lot of keratin, so they consider it pre-malignant, means it can lead to the cancer. So this is all about this non-cancerous lesion. This is just explanation of the same thing, the last slide. The hyperkeratosis is there, superficial cells are swollen, and the epithelium forms downgrowth due to hyperplasia of basal layers. So hyperplasia is there mainly. This dermal papillae means this in between, this dermal papillae, they are long because it's going down. But means this layer is going down, so obviously this layer will be more. And underlying tissue is inflammation. Okay, so we have covered almost this lecture, non-neoplastic lesion. Only one slide for the neoplastic lesions. Not all neoplastic lesions, only the squamous cell carcinoma. Rest of it you will cover in some other module. So what about the squamous cell? The important point is that, now look at this lesion. Raised everted edges. Raised means more, everted. Means it look at this dip inside, just like some gutter, there's dip inside. So everted edges mean edges are protruding. Okay, necrotic hemorrhagic floor. So the floor in between area, which is the floor, is necrotic and can be hemorrhagic, blood can ooze. Indurated base. So the same explanation, that base is indurated. That's why bleeding is occurring. So under the microscope, this is very important. Very important, I'm saying that this is very important, specific to this squamous cell. What is that? That pleomorphic groups of polygonal malignant cell invading the subepithelial, and these groups shows this central keratin pulse or cellness. Look at this. Under the microscope, you will see this. These lesions rounded. Okay, pearls. What is pearl? No, pearl. I think you call it lolo in Arabic. So it's just like rounded. Okay, central keratin pulse. So of keratin, the pulse like rounded structure is there. So they call it pearl, keratin pearl. Okay, this is specific of this squamous cell carcinoma. Okay, so again look at this, just like something like a pearl. So anyway, Samoma body, I don't think so. There's something else. Okay, this kind of lesions in the is specific for squamous cell carcinoma. That's why I'm insisting and emphasizing on that. Because there's some very key relationships useful for you in the future exams, in the postgraduates also, that if some words is there, disease should be known. So if somebody asks you in which disease these keratin pulses are seen, straightforward answer, squamous cell carcinoma. Okay, so this very means there's strong relationship between them. So this is all about today's lecture. Very simple lecture. If you know the name, understand the name of the disease, you can understand the explanation of the disease. Any question, anything you want to ask, you are most welcome.